Inclusion Health team at Birmingham Public Health. I've been the lead on the Gender Health Project, and I will be walking you through today's session on the Birmingham Men's Health Report. I'm hoping this will be a really informative and engaging session for everyone, so please feel free to grab yourselves a drink or a cup of tea so you can get yourselves settled in. So just some quick housekeeping rules. Can everyone please turn their cameras off to ensure that there are no disruptions with the feed? Can I please ask everyone to keep their mics on mute, and feel free to use the chat function for any questions or comments. Please note that this session is being recorded and will be uploaded on our web pages and on YouTube. My colleague Marina will be supporting today's session and monitoring the chat. Marina, did you just want to introduce yourself very quickly?
Yeah, hi everyone. My name is Marina Davidson. I'm a Senior Inclusion Health Officer at Birmingham City Council, so nice to see you all.
Okay. Just before we start, I'd like to take the time now to give a brief content warning that in the following presentation, we will be discussing topics that some people may find sensitive, including premature mortality, substance misuse, and suicide. So please feel free to take a break away from the screen if you feel affected at any point during the session. We've also included some links that you can click on the screen to local and national organisations that you can get in touch with if any of today's topics affect you. So we're going to kick things off with a few words from our Cabinet Member for Health and Social Care, Councillor Mariam Khan, who is really committed to this work and a key advocate of applying a gender lens when assessing health outcomes and inequalities. Get this started. Okay. So to continue on from Councillor Khan's opening speech, I thought it would be useful to provide some brief context on the Gender Health Project. So the Inclusion Health team developed a Gender Health and Equalities project in late 2022, which aims to influence and support the delivery of local action to reduce health inequalities affecting women, men, transgender and non-binary populations in the city. The key priority for this project has been to build upon the local evidence base to support targeted intervention based on women and men's specific health needs. and to support service providers and community organisations in empowering residents to improve their health and well-being. As mentioned, for phase 1, we focused on women's health needs in the city. All the information and data was consolidated into a final report, which was underpinned by the 2022 National Strategy for Women's Health in England. The report was published last year and launched formally at the Birmingham and Solihull ICS Women's Health Conference, and we're really pleased that it fed into shaping the local women's digital health hub and is already shaping commissioning priorities across relevant service areas in the local healthcare system. We've since progressed on to phase 2, men's health needs, the focus of our session today. We adopted a similar logic model to phase 1 using the priority areas and aims for this report against a 2022 white paper from the all-party parliamentary group, which advocated for a national men's health strategy. And I'll be touching upon these in the following slide. It's worth noting that Birmingham has submitted the early findings from this report to the Department of Health and Social Care in the summer as part of their call to evidence in developing the National Strategy for Men's Health in England. So we're working on the assumption that the strategy will be published within the next 12 months. But within Public Health and Inclusion Health, we have already made a commitment to start distributing this report with relevant forums and multi-agency networks to ensure that the findings can feed into action at the earliest point possible. So, as mentioned in the previous slide, the case for a men's health strategy has underpinned our approach to the Birmingham Men's Health Report, as it informed our logic model for identifying gaps and needs in relation to the health and well-being of men in Birmingham. We focused on 7 of the core priority areas listed below, which we have used to guide our data and evidence building. These core priorities were premature mortality, cancer and cardiovascular disease, mental health and suicide, alcohol and substance misuse, and risk behaviours. The aims of prioritising what works, understanding how men and boys access help, reducing disparities, boosting a preventative approach to health promotion, and driving to improve the evidence base are all weaved throughout each of these themes. So moving on to our methodology, we started our research by engaging with local stakeholders, which includes a number of statutory and non-statutory services that provide health and wellbeing support to men in Birmingham. These include practitioners and subject matter experts from the Birmingham and Solihull Integrated Care Partnership, University Hospital Birmingham, Birmingham Public Health, Birmingham-based GPs, and a number of partners across services such as Change Grow Live, the Aston Villa Foundation, the West Midlands Cancer Alliance, and third sector partners like Mind's Eye CIC. Through this engagement, a stakeholder advisory group was set up to drive this project. And whilst we predominantly engage with services and organisations, through them we have received feedback from their service users. Let's need to take this off my screen. That they have been collecting as part of their work, and these have informed the findings and recommendations within the report. Where there were significant gaps or limitations in the data, we conducted a supplementary review of published evidence, focusing specifically on men's health, which used the thematic areas from the APPG report, and this review included great literature and qualitative local research. We then consolidated and synthesized this research with local and national datasets, such as the Joint Strategic Needs Assessment, the Birmingham Community Health Profiles, locally collected NHS health check data, and the National Public Health Fingertips data, and the National Drug Treatment and Monitoring System. All of the findings discussed today have been extracted from the Birmingham Men's Health Needs Report, and the full report and additional resources will be available on Birmingham City Council's Health and Wellbeing section online later today, the Birmingham City Observatory, and we will ensure to distribute these slides to all attendees signed up for this session later on. So now we're going to move on to the key findings, and before we do that, I wanted to give a special thanks to our brilliant colleague David Collier. He's a GP registrar and a consultant in public health who helped to co-author this report and helped to also shape the feedback sessions with practitioners. I've got some pretty big shoes to fill, as he was unable to be with us for today's webinar, but his clinical lens on men's health really helped to strengthen our data collection and interpretation to really shine a light on the issues impacting men in the city. So we're going to start off with an overview of Birmingham's male population. The Office for National Statistics 2021 census data shows that gender distribution between males and females is relatively equal citywide and at the ward level. A bit more background and context for the city of Birmingham. Birmingham is considered Europe's youngest city, with under 25s accounting for nearly 40% of the population. And the age profile of the city is important to consider for several of the key themes, particularly around risky behaviours and mental health. Of the 11 core cities in the UK, Birmingham has the highest percentage of residents from ethnic communities outside of London. And once again, this matters, especially against the backdrop of widening health inequalities and disparities. We stumbled into some difficulties obtaining specific numbers on the proportion of the male population that identified as LGBT, but based on the ONS data, we've estimated that approximately 0.9% of the male population identifies as LGBT. Deprivation is also heavily clustered around the city centre and the city core, and we'll expand on this further in the next set of slides. So, moving on to the intersectionality between gender and deprivation, we know that gender shapes health inequalities and men face distinct barriers to good health. Biological risks such as prostate cancer, combined with social pressures like norms which encourage risk-taking and discourage help-seeking, limit men's access to care and influence their health decisions. We framed our approach through the social determinants of health framework, which highlights specific social factors that are crucial for understanding health outcomes. These factors include ethnicity, sexual orientation, class, cultural norms, and disability. There are strong links evidence between poverty, social exclusion, and life expectancy for both genders. And the national data backs this up, as represented in the chart on the right-hand side, showing a clear gradient between deprivation and premature mortality. As deprivation increases, so do the years of life lost before age 45. And this trend raises important questions for all of us. But deprivation is especially important for our local context, as Birmingham is ranked as the 7th most deprived local authority in England, and men in deprived areas experience much worse health outcomes across the life course. The evidence team in public health have developed a railway map, which can be found within section 4.1 of the report, that illustrates this clearly. Life expectancy varies dramatically by postcode in Birmingham. The average life expectancy of a male in Witton is lower than a male in Sutton Coldfield. What this means for our communities is that there is a need to adopt a place-based approach, factoring deprivation into gender analyses to reflect the specific risks faced by different male populations within the city. We took a closer look at premature mortality for men in the city, and the Office for Health Improvement and Disparities data highlights that there are clear disparities between Birmingham's male population compared to the local female population and compared to men in England. Men in Birmingham are 30% more likely to die prematurely than men across England. And this is clear to see on the graph, the right side of your screen, where the under 75 mortality rate for men in Birmingham is significantly higher than men in England and women in Birmingham. Expanding further on the emphasis on the importance on locality and deprivation, men in Birmingham's most deprived neighbourhood, Ladywood, are on average more than 3.5 times as likely to die prematurely than men living in Beckenham in the south of England. Continuing on with premature mortality, a male baby born in Birmingham today has a reduced life expectancy by 4.6 years than a female baby in the city, and has 2.1 fewer years than an average male baby born in England. The average male in Birmingham can expect to endure poor health almost 7 years before state pension age. And every figure here represents someone's father, son, brother, or friend. So our next part of the session focuses on one of the most pressing challenges, cancer and cancer screening. What really brings our case clear for a gender transformative approach to reducing health inequality lies here within the cancer data. And here's what the numbers revealed. The second leading cause of cancer mortality is gender specific, prostate cancer for men and breast cancer for women. In the UK, cancer causes around 1 in 4 deaths, and cancer mortality rises sharply with deprivation for both men and women. In England, socioeconomic inequality drives an estimated 19,000 additional cancer deaths every year. So I just want everyone to take a second to picture an entire football stadium filled with 19,000 people, every one of them dying from something that could have been prevented. That's the scale of the issue we're dealing with nationally, and it's easy to kind of overlook that when we're just looking at data, but there are people behind these numbers. So from the local picture, in 2023, the average man in Birmingham was nearly 9% more likely to die from cancer than the national average for males. And of particular note, prostate cancer risk is shaped by both gender and ethnicity. Black men face double the rates of prostate cancer compared with white men, with a 1 in 4 lifetime risk versus a 1 in 8 lifetime risk. This elevated risk doesn't occur in a vacuum. It reflects a long-standing mix of unequal access to screening, later stage diagnosis, and gaps in how research and services have historically engaged Black communities. And whilst there's more encouraging data predicting cancer mortality to decrease for both genders over the next 15 years, this does not mean we can afford to take our foot off the pedal. Prevention for liver cancer remains a priority, as liver cancer mortality has increased by 45% over the last 10 years. We also found that cancer screening uptake in Birmingham is amongst the lowest in the country. Inequalities across screening pathways drive late diagnosis, which is one of the biggest contributors to cancer deaths. And the stark disparities highlighted above show why cancer screening and early detection interventions must be accessible, gendered, and ethnicity specific. Now we turn to the other major driver of men's health inequalities, cardiovascular disease. Cardiovascular disease is the single largest contributor to life expectancy inequalities in Birmingham, and circulatory diseases account for more than a quarter of all male deaths. Despite declining since the mid-1960s, coronary artery disease remains the single most common cause of death for men nationally. In Birmingham, for every 10 women that die prematurely from this cause, a total of 23 men will die. Birmingham men are a third more likely to die prematurely from cardiovascular disease than the national average. Ethnic inequalities also compound the issue, with South Asian and Black men experiencing disproportionately high rates of heart disease and stroke. 2017 to 2019 ONS data shows that South Asian ethnicities, so Bangladeshi, Indian, and Pakistani, have higher rate heart disease mortalities than the white population. For example, Bangladeshi men have a 39% higher mortality rate from heart disease than white men. And this is all despite the fact that up to 80% of cardiovascular disease is potentially preventable. I know this looks like a lot of numbers, but don't worry, our research also shows that there can be a positive direction of travel here, and that is that there's room for change, for early intervention, better ways of helping communities through blood pressure management and lifestyle support. So we'll start to go on to some of the key findings around lifestyle and preventable risk factors. And we picked up one for focus today, which is hypertension, often known as the silent killer, which is particularly concerning. And Birmingham men are 46% more likely to have higher blood pressure. High blood pressure contribute to mortality than women, and 37% are more likely than an average man in England. But here's the breakthrough. We found that 90% of coronary artery disease are linked to 9 factors that we can change, and these include hypertension, smoking, diet, alcohol, and lifestyle and obesity. So within the report, we've chosen to narrow in on smoking, as its impact on men's health is hard for us to ignore. We examined evidence collected through optional NHS health check data to understand and identify specific health behaviours which perpetuate gender health inequalities, and this data was compounded with ethnicity and deprivation. Through the NHS health checks, we found data between 2018 to 2023 that consistently shows higher smoking prevalence amongst men than women across all ethnic groups. Locally, smoking remains higher than national rates. Black and Asian men show lower smoking prevalence, though still higher than their female counterparts, and this suggests that ethnicity intersects with gender in determining smoking behaviours. And once again, deprivation clearly plays a role. Men in deprived areas and in routine or manual jobs in the city smoke at markedly higher levels, and this is also the case for men with long-term mental health conditions. So when we look closely, it's clear that smoking prevalence isn't evenly distributed. Gender and deprivation amplify this risk. And there's already positive action taking place, which we expand upon within the report. But one such example is engagement programs being delivered by third sector partners, such as Mind's Eye Development. They were able to successfully deliver a walking football tournament for Black men aged over 40. Football was used to engagement locally, and then they were provided a mobile health services such as prostate cancer screening, comprehensive health checks for BMI and blood pressure, and smoking cessation advice. And initiatives like this are the springboard for targeted, meaningful actions, and we've listed a number of them and dotted them across the report where you can see best practice of men's health interventions. So we moved on and narrowed in also on diabetes and obesity. And the picture gets even more complex when we looked at diabetes and weight management, two risks that often go hand in hand. Diabetes prevalence in Birmingham sits at 9.2%, significantly above the national average. And we also see a clear pattern, higher prevalence in South Asian communities, higher complication rates, and there are strong links, once again, with deprivation and significant overlap with obesity rates, as illustrated by figure 15 on the right-hand side of this screen. Between 2022 to 2023, 39% of Birmingham residents are overweight and just under 26% are obese. This is compared to 26% in England. Obesity affects more than a quarter of residents, and again, men are less likely to engage in weight management support. And this was evidenced by the Be Active Plus exercise referrals, which show a persistent gender imbalance. Women outnumber men by a large margin. And what all of the above tells us is clear, the way we currently engage men isn't working, and when engagement fails, prevention fails, leaving risks like cardiovascular disease, diabetes, obesity, and smoking unchecked. These aren't isolated problems, they're interconnected drivers of premature mortality. And if we want to change this trajectory, we need approaches that resonate with men, meet them where they are, and turn insight into action. And that's kind of what Mind's Eye were doing with the walking football tournament. So now we come to what is arguably the most emotionally challenging part of today's discussion, and it's mental health and suicide. 1 in 4 adults in Birmingham have a mental health condition. For men, the risk of poor outcomes is amplified by social pressures, stigma, and gender norms that discourage help seeking. National and local suicide rates for men have been steadily increasing over the last few years. For Birmingham, the male suicide rate sits at 14.1 per 100,000. That's nearly triple the local female rate. And emergency hospital admissions for intentional self-harm for males in Birmingham is higher than the England rate. We also found that men aged 45 to 49 have the highest suicide rates nationally, reflecting the cumulative pressures of financial instability, relationship breakdown, loneliness, loss of identity, and chronic stress. We've dived into these risk factors a little further. With relation to financial instability, research by Samaritans demonstrates a strong link between deprivation, financial insecurity, and unmanageable debt, and an increased risk of suicide in men. Economic stressors, including unemployment and job instability, compound mental health challenges, particularly for men who may already be reluctant to seek help. And in the UK, 75% of suicides are male, with many associated with emotional distress following relationship breakdown. The statistics are quite alarming, actually, because men who are separated face a 4.8 times higher risk of suicide, which rises to 8.6 times for men under 35. A significant factor is the loss of access to children post-separation, with many men reporting feelings of disconnection from their children. And this emotional stressor strongly correlates with increased suicidal ideation. We also took a look at traditional gender expectations, such as the idolization of alpha males who encourage stoicism, emotional restraint, and risk-taking. And you can see it on the right side of the top side of the screen. I won't name any names, but I think we all have a popular figure that comes to mind that exemplifies the kind of phenomena we're talking about when we think about the glorification and idolization of alpha males. But all of this is not just internet fodder. It has serious implications as it can reduce men's engagement with mental health services. These norms contribute to underreporting of emotional distress and delayed help seeking amongst men. Men often adopt alcohol and substance misuse as coping mechanisms for low mood, anxiety, and emotional distress. These behaviors not only worsen mental health outcomes, but also increase the risk of suicide, particularly in context of financial or relational stress. We found that men's mental health outcomes are shaped by a combination of structural, relational, and cultural factors. Financial insecurity, family breakdown, restrictive gender norms, and risky coping behaviours intersect to heighten vulnerability. So effective interventions must address these dimensions, promoting emotional support, access to mental health services, and community-based strategies that challenge harmful stereotypes and provide practical support. What we're looking at, it isn't just data, it reflects real lives shaped by stigma, isolation, and unmet support needs. So I'll be expanding on the previous slide. Approximately 1 in 4 adults in Birmingham experience a mental health illness. This aligns with national trends but masks important inequalities within specific male populations. Mental health issues in men are often under-recognized and undertreated, partly due to stigma and lower help-seeking behaviours. We also see disproportionately high risks amongst Black Caribbean men, gay and bisexual men, and men with long-term mental health conditions. Black Caribbean and Black African males are at higher risk for adverse mental health outcomes, and this is shown by suicide rates amongst Black Caribbean males, who are the third highest nationally after white and mixed groups. These disparities highlighted the need for culturally sensitive mental health interventions. Gay men and men who have sex with men report higher prevalence of depression, anxiety, suicidal thoughts, and self-harm intentions. A 2016 report emphasised that targeted support is essential to address these vulnerabilities. And when we took a view on inclusion health, we know that homeless men in Birmingham face extreme mental health challenges. A 2014 health audit over 2,500 homeless individuals in England revealed significantly higher prevalence of mental health issues. By 2019, 88.3% of deaths amongst the homeless population nationally were male, illustrating a clear gendered vulnerability. As mentioned before, employment and financial instability exacerbate mental health risks. About 66% of adults aged 16 to 64 receiving employment and support allowance have a common mental health condition, and nearly half of ESA claimants have attempted suicide. Birmingham faces structural economic challenges, including the highest claimant unemployment rate amongst the core cities. Job instability and financial stress directly contribute to anxiety, depression, and suicide behaviours in men. Older men are also at higher risk of social isolation and suicide. And we found that through the Birmingham 2024 Mental Health Survey, it highlighted the importance from residents about community spaces such as cafes to help reduce loneliness in older males. And loneliness can act as both a risk factor and a barrier to accessing mental health support. The evidence for us consistently pointed to the need for targeted interventions for men in Birmingham, and the recommendations spanned across culturally competent mental health services, community-based interventions to reduce isolation, employment support and financial guidance for at-risk males, and campaigns to address stigma and encourage help-seeking behaviours. Male mental health in Birmingham is shaped by a complex interplay of ethnicity, sexual orientation, socioeconomic status, and social isolation. Addressing these disparities requires a multi-layered approach that combines clinical support, community engagement, and structural interventions. By implementing targeted strategies, we can reduce inequalities, improve well-being, and save lives. So behind the statistics on mental health lies another key challenge: addiction. This is a key public health issue. Research shows that men are disproportionately affected by risky substance abuse, which not only exacerbates their mental health challenges, but also has profound negative impacts on their families and wider society. Alcohol is one of the leading risk factors for ill health, early mortality, and disability, particularly among individuals aged 15 to 49. Its impact on men in the UK is especially concerning, reflecting a specific gendered risk in both consumption patterns and dependency. In Birmingham, data from 2019 to 2020 shows that alcohol dependency amongst males was nearly 4 times higher than in females and higher than the national rate for men in England. And I just want everybody to take a second to pause for a moment and imagine what that means in real lives. The stark disparity highlights the disproportionate burden that alcohol misuse places on men at both individual and community levels. And the consequences are profound. In 2023, potential years of life lost due to alcohol-specific conditions for men in England was 1,246 per 100,000. That's double the rate for women. And beyond physical health, excessive alcohol consumption use significantly impacts male mental health, increasing risks of depression, anxiety, suicidal ideation, and engagement in other risky behaviours. When alcohol misuse becomes the default coping mechanism, the cost isn't just health, it's lives, relationships, and community resilience. And we need approaches that disrupt this pattern. So as illustrated on the figure on the right-hand side, we're going to be discussing the hospital admissions and the impact on services. So hospital admissions for alcohol-specific conditions in Birmingham have consistently exceeded the national average for England, reflecting the significant public health burden of alcohol misuse amongst men. Specifically, admissions for mental health and behavioural disorders due to alcohol use amongst males have remained relatively stable over the last 6 years, indicating a persistent and ongoing challenge. In 2023 to 2024, the rate of hospital admissions for males in Birmingham was 739 per 100,000. This is substantially higher than the England average of 575 per 100,000. By contrast, female admission rates in Birmingham were much lower at 227 per 100,000, highlighting the gendered nature of alcohol-related harm. And this is a two-way street. Mental health challenges can lead to substance misuse, and substance misuse worsens mental health. Drug misuse also represents a growing public health concern in Birmingham, with mortality rates steadily increasing with a specific gendered risk to men. Between 2016 to 2018 and 2020 to 2022, the mortality rate from drug misuse rose from 6.1 to 7.8 per 100,000, exceeding the national average of 5.2 per 100,000. And in terms of prevalence, data from 2019-2020 shows that illicit opiate and/or crack cocaine use amongst males in Birmingham was 3.65 times higher than among females and substantially higher than the England average. Male opiate use in the city also exceeds the national average of 11.18 per 1,000, whereas rates for females, though above the national average, are not significantly so. And the ethnic breakdowns indicate that white British males account for 71% of males in treatment for drug and alcohol services in Birmingham, reflecting both patterns of use and engagement with local treatment services. These trends make one thing clear: drug misuse amongst men is not only persistent but deeply gendered, driving mortality, straining health services, and creating ripple effects across communities. Tackling this demands targeted prevention and support strategies that meet men where they are. So we went into a deep dive on risk factors, particularly with a focus on inclusion health groups. It's really interesting actually because I was at the Birmingham and Solihull Inclusion Health Living Libraries event yesterday, where people with lived experience of the very subjects we've just spent the last 30-40 minutes talking about said that big organisations in the city focus way too much on statistics. They want their experiences and their life journeys to be understood and reflected in their treatment services. And it's something that I'd really want us to sit on and take away. Through the service user insight, as well as the grey literature, we wanted to pick out some of the wider determinants surrounding substance misuse. Substance misuse amongst men in Birmingham is influenced by a complex interplay of social, economic, and psychosocial factors, many of which are shown to be gendered risks. Inclusion health populations, such as people experiencing homelessness, those with learning disabilities, and those in contact with the criminal justice system, face extreme health inequalities. A large majority of these groups are men. The alcohol harm paradox illustrates that men living in poverty or experiencing deprivation often suffer disproportionately severe harms from alcohol and illicit drug use, particularly opiates and crack cocaine. Economic disadvantage not only increases exposure to substances, but also reduces access to treatment and support, amplifying the health and social consequences. We also found that men with learning difficulties and disabilities are at higher risk of substance misuse due to heightened vulnerability, social isolation, and limited access to tailored services. Broader mental health conditions, including depression and anxiety, often co-occur with substance misuse, creating a cycle of harm. As we've mentioned, living alone, loneliness, low self-esteem, negative life events, and lack of meaningful occupation all increase susceptibility to substance misuse. These factors underscore how social isolation and a lack of purpose or routine can exacerbate risk behaviours amongst men. Trauma, including adverse childhood experiences and PTSD, is strongly associated with later substance misuse. And exposure to physical abuse and violence during childhood or adolescence significantly increases the likelihood of drug and alcohol use amongst young men. These experiences often shape coping strategies, with substances being used as a way to manage emotional pain. and men in their 20s and 30s experience the highest prevalence of homelessness in the UK and Europe. Studies also indicated that housing instability and homelessness are recurring issues amongst drug-using populations, often alongside low educational attainment and unemployment. Drug use is frequently both a pathway into homelessness and a consequence of it, creating a vicious cycle where housing instability and substance misuse reinforce one another. A significant proportion of individuals who are homeless experience alcohol or drug problems and have a lifetime history of substance disorder. So substance misuse in men is not limited to health consequences, it also increases suicide risk, particularly when combined with mental health challenges and social isolation. It contributes to criminal justice involvement, as engagement in illicit drug use can intersect with legal issues and societal marginalisation. And these factors highlight that substance misuse amongst men is multidimensional. It's shaped by socioeconomic disadvantage, psychosocial trauma, mental health vulnerabilities, and structural barriers such as housing instability. These findings once again call for targeted trauma-informed support that speaks directly to men's experiences. It's important that we address the immediate harms of substance use and the underlying social determinants, including housing, mental health support, and access to meaningful activities. So now we've gone on and moved past the key and core findings from the data. I would like everybody just to take a second to pause. I know that was a lot of information to take in. And we're going to now look at some of the engagement feedback from practitioners and their service users. So during our engagement with local stakeholders and their service users, we were able to compile rich local insight and perspective on some of these areas. And local practitioners highlighted that men have a lack of trust in services, there needs to be improved engagement and messaging, better considerations for occupational health, the role of unemployment in men's health, and that certain groups are underrepresented in substance misuse services, and emphasised the need for support for men experiencing child custody issues, and highlighted that middle-aged men need to be aided in suicide prevention. And this is also backed up by some of their service user data and their service user perspectives that advocate consistently for a bespoke men's mental health service, as mental health remains a taboo subject amongst men across the city, men and boys across the city. The service users also highlighted that sport and activities could play a really key role in engaging men to promote healthy behaviours and support overall well-being across the areas that we've highlighted. So through the stakeholder group, we were also able to compile a list of services across Birmingham offering support. So the image on the right-hand side of the screen represents the service map available to view on page 8 of the report, as we were unable to copy across onto the slides. But I have pulled out some of the targeted programs from the map, which include activities and organisations like CGL Open Events and Outreach specialising in substance misuse recovery, ACOC Screen Men's Shed, tackling social isolation and loneliness amongst older men. Birmingham Mind, which offers specific men's health group, a domestic abuse group and sexual trauma groups. Mind's Eye CIC, which offers a number of targeted activities for Black men. Legacy West Midlands offers a range of services to support men's health literacy and well-being. And the Men's Mental Health League, delivered by Birmingham County. And there are many more. And our hope is that we can continue to expand on the current local offer to get more men the support that they need where they are. And once again, just to emphasize that within the report itself, there are case studies of best practice examples, not just locally, but nationally. So that was a lot of information to take in. I'm going to now give a very brief summary of the key findings. Deprivation, from everything that we've discussed so far, deprivation underpins nearly every health disparity. Men in the most deprived neighbourhoods are more likely to die prematurely than those in affluent areas. And life expectancy varies within the city by geography. Deprivation interacts with multiple risk factors: unemployment, low income, housing instability, poor diet, and limited access to healthcare. Men face unique risks due to social expectations around stoicism, risk-taking, and reluctance to seek help. Gender norms exacerbate mental health challenges, substance misuse, and engagement with prevention programs. Men are disproportionately affected across nearly all health indicators: premature mortality, suicide, substance misuse, cardiovascular disease, and lifestyle-related conditions. We also know that Birmingham men live 2 years less than men nationally and spend 7 years in poor health before state pension age. And their major causes of death are cardiovascular disease, cancer, and liver disease. We know that now Black men face higher prostate cancer risk, highlighting the intersection of ethnicity and gender in health disparities. Men in deprived areas disproportionately experience preventable mortality linked to lifestyle and healthcare engagement gaps, and that there are modified risk factors, including smoking, poor diet, physical inactivity, and hypertension, which account for the majority of coronary heart disease. Men in routine or manual jobs have higher smoking rates and are less likely to engage with weight management or health programs. And diabetes and obesity show strong links with deprivation and ethnicity, particularly among South Asian communities. From the last few sections, we also covered that 1 in 4 adults in Birmingham has a mental health condition, and suicide rates amongst men are nearly triple those of women, peaking in midlife, so around 45 to 49 years old. And the risk factors include financial instability, relationship breakdown, loneliness, loss of identity, trauma, and cumulative stress. And that Black Caribbean men, gay men, and bisexual men, homeless men, unemployed men, and men with long-term mental health conditions are disproportionately impacted. And substance misuse is a gendered risk. Men are likely to develop drug and alcohol conditions, with drug-related mortality rising, and men experiencing double the potential years of life lost due to alcohol-specific conditions. We've also covered that substance misuse interacts with mental health, family breakdown, homelessness, trauma, and criminal justice involvement. Most importantly for our conversation, men dominate inclusion health groups, homeless populations, people with learning disabilities, and those in contact with the criminal justice system. Their key compounding risks: instability, low education, prior trauma or violence. So we come on to the point, and the most important point of this entire presentation, that services for these men must be trauma-informed, non-judgmental, culturally sensitive, and accessible. Across the board, men's health in Birmingham is shaped by intersecting determinants: deprivation, gender norms, ethnicity, sexual orientation, social isolation, and structural disadvantage. Many outcomes, from cardiovascular disease to suicide to substance misuse, are preventable but require targeted gender and context-sensitive interventions. There's a need for targeted male-focused approaches, and I hope that has been able to come through the presentation. And the evidence highlights missed opportunities for early engagement, health promotion, and preventative care. So effective strategies must combine community-based interventions and initiatives, culturally competent screening and health education, trauma-informed and male-responsive services, and support for employment, housing, and exclusion. And that's the end of this part of the presentation. So I'll now be passing over to my colleague Marina to go through our recommendations very briefly, our next steps, and closing off the session.
Thanks, Yasmin. Can you just go to the next slide? Thanks. So we've covered a lot of the challenges in detail, and we're just going to finish by looking at some of the key recommendations. So the report sets out 30 recommendations across 6 thematic areas. I'm not going to read through all of them now, but they are available in the slides and in the final report. We'll share both of these after the session, but just to highlight some of the key principles from these recommendations. So firstly, meeting men where they are, that's physically, culturally and emotionally. Prioritising prevention, as we've mentioned, so particularly thinking about blood pressure checks, smoking cessation, cancer awareness and screening, and early mental health support. Recognising the need for tailored interventions, so we know that universal approaches aren't effective, so interventions need to be adapted to reflect the needs of different populations, communities and local contexts to make sure that they're relevant and accessible. Also strengthening trauma-informed practice and training for mental health practitioners, using trusted messengers in communities, so including sports clubs, peer groups and community leaders. Improving access to services, so through out-of-hours provision, community-based locations, flexible models, and by involving men directly through outreach and co-design of services. Increasing representation and data quality, particularly for minoritised men, LGBT men, and those in inclusion health groups. expanding integrated community support and outreach to people experiencing homelessness and exclusion, and finally localising and diversifying male-focused health campaigns so they resonate with the communities that they're intended to reach. So these recommendations are all practical, they're evidence informed based on the data that we've seen today and designed to support effective action. Next slide, please. So to finish, we just wanted to briefly outline some of the next steps and some related upcoming projects. So obviously the issues that we've discussed today are really broad and they have relevance across the entire public health system and beyond. We look forward to the publication of the National Men's Health Strategy and to building on the work happening in Birmingham so that we can align locally with the emerging national priorities. Within the Inclusion Health team specifically, we're already progressing several areas highlighted in the report, particularly those affecting marginalised groups and where men are disproportionately impacted. So this includes the Justice Health Needs Assessment, which is due to launch in early 2026. We'll also be conducting a Vulnerable Migrant Health Needs Assessment, which will look at the experiences and needs of men and the impacts of insecure immigration status, so particularly thinking about men going through the asylum system, for example. Yesterday, as Yasmin mentioned already, was the launch of the Living Libraries, Birmingham Living Libraries, which is an ongoing opportunity to amplify the voices of people with lived experience across our work and will, of course, highlight specific challenges that men face. We're also developing a stigma and shame competency framework, which will equip services with knowledge and tools to understand and respond to stigma and reduce barriers to access. And then finally, the integrated support for the extremely excluded project, which will develop an integrated model of health and wellbeing support for those who are experiencing the most extreme forms of exclusion and destitution, as well as multiple disadvantage. So that's all from us. I'll have a quick look in the chat to see if there's any questions. We'll email the report and the slides once they're available on the webpage. The session recording will also be available on the website and on YouTube. I'm just going to pop in the chat the Public Health Inequalities inbox. So if anyone's got any questions on this report or would like to find out more or support the wider work of the Inclusion Health team and some of the projects that I've just mentioned, then feel free to get in touch. And otherwise, if there's not any questions, just leave it a couple of minutes, so feel free to put those in the chat now. But we might be having a few minutes back. I will also put the link to the Gender Health Inequalities webpage, so that's where the report will be published later on today. Can't see any hands up or any questions, so I think we will probably leave it there. Oh, Michael, did you want to come in?
Yeah, I couldn't type quickly enough. Now, a couple of things. First of all, thank you very much. It's very, very comprehensive. I'm pleased to have been involved in the to be involved going forward.
I think you're breaking up.
We've lost you a bit there.
We've lost your feed. Michael, I think we've lost your feed.
Oh, sorry.
Oh, you're back now.
Sorry. Yeah, the short version, yeah, well done. Could a summary version of this be provided for us to circulate within communities?
Yes, we will be producing a summary version for you to share.
Great. Thanks very much.
Thanks, Michael. Any more questions before we finish? No? Okay, so the email address is there if anything comes up later on. But otherwise, thanks very much, everyone, for joining today and taking the time out of your day. And happy International Men's Day. Thanks, everyone. We'll be in touch with the recording and the slides soon.